professor in family medicine, associate member at the Institute of Health Science Education, and director of the Family Medicine Education Research Group. And we are the pleasure today to receive an exceptional guest speaker. I will pass the word to Vera Granikov, who is a former graduate, McGill graduate, currently a research associate at the Research Institute of the CHUM, the Centre Hospitalier de l'Université de Montréal. And she will introduce our guest speaker, and also to mention that is the last webinar of this year, so we couldn't close the 25-26 academic year in a better way. So Vera, go ahead.
Well, thank you, Charo. So it's my pleasure to introduce Dr. Fadzilah Hanum Mohd Mydin. I hope I pronounced everything correctly, who is an associate professor and family medicine consultant at Universiti Malaya in Kuala Lumpur. And she's interested in improving care for older adults, particularly addressing elder abuse, social isolation, and promoting healthy aging. And I'm especially happy to be here today, as this award is named after Pierre Pluy, who was my doctoral supervisor and mentor for over 15 years. So it's especially meaningful for me to be here today with you. And please join me in welcoming Fadzilah. And just to say, in terms of the format, that she will be presenting for about 30-40 minutes, and then we will have a period for questions at the very end. Thank you. Go ahead.
Thank you. Thank you, Vera, for your kind introduction. In my side, it's already early morning, but I wish you all good afternoon, and thanks for joining this webinar. Can I share the slide? I will share the slide, right? Can you see?
Yes, perfect.
Yes, okay. Okay, so good afternoon, everyone. Again, thank you for joining this webinar. My topic for this webinar is strengthening family doctors' response to abuse of older people, lesson learned from a Malaysian education intervention. As our population age, the well-being, safety, and dignity of older adults have been increasingly important concern. Abuse of older people is a serious breach of human rights and dignity. It often happens within a relationship of trust and dependence, making recognition and intervention more challenging. Despite this complexity, we share a responsibility to ensure older adults can age safely with respect and autonomy. Today's session will focus on helping family doctors to address abuse of older people in Malaysia. This is the outline of my talk. I will cover the abuse of older people, what it means and why it matters. I will also discuss the role of family doctors and the challenges they face. And then I will introduce the SAFE program and share findings from its evaluation to show how it works in practice. So what is abuse of older people? It's a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust which causes harm or distress to the older person. This is as defined as the action of Elder Abuse UK and the International Network for Elder Abuse. So abuse of older people can take many forms. For example, physical abuse causes pain or injury through force or restraint. Psychological or emotional abuse creates fear or emotional suffering. Financial abuse involves the misuse of money or property. Sexual abuse is a non-consensual sexual contact, while neglect occurs when caregiver fails to meet basic needs with serious consequences regardless of the intent. So why abuse of older people matters? Okay, so abuse of older people is a rising concern as population age. Many live longer with chronic illness or dependency, risking greater harm. Families are getting smaller, caregivers are stretched, and adults support both parents and children. So for example, in Malaysia, many of us are living in a sandwich family in which the working group are supporting their older adults as well as their own children. So social isolation, financial dependency, and limited legal protection complicate detection and response of abuse of older people. And this ultimately, abuse of older people violates safety, dignity, and respect, and it's demanding urgent attention. So let's look at the prevalence of abuse of older people. Globally, about 1 in 6 people aged 60 and above experience abuse annually, with psychological abuse being most common, followed by financial, neglect, physical, and sexual abuse. While in institutional setting, around 2 in 3 staff admitted or reported abusing the resident, mainly psychological, followed by physical and neglect. This statistic reveals that abuse of older people is often widespread and hidden than believed. So this is the recent review published. So it shows that this paper analyzed 94 studies from 35 countries since 2000, mainly from high-income regions like Europe, Asia, and North America. The global prevalence of abuse of older adults is around 27.6%, likely is underestimated due to stigma and underreporting. And the paper or the review found that higher rates in upper middle income country, which may reflect because they have a better detection, whereas lower income country tend to be underreported. South America and Asia have highest prevalence, perhaps influenced by their cultural norms and economic pressure. Studies among women shows that they have a higher prevalence compared to men, right? And while in the institutional setting, the abuse is higher compared to the community. So overall, abuse of older people is widespread, undetected, and is a global concern. So the question is, what drives abuse of older people? To prevent and address it, we must understand that risk factor increase the vulnerability and protective factor can reduce the harm. Okay, research used the ecological model. For example, here, the ecological model. Originally, this was used to explain the risk factor of child abuse, and they consider a few factors, which is the individual, relationship, community, as well as the society, which interact with each other and increases the risk of abuse of older people. So examining all these factors help us to understand why abuse occurs and how to prevent it. So abuse of older people, it results from multiple factors. For example, at the individual level, the traits of the perpetrator, like substance use or mental health issue, and victims such as their age and social isolation matters and increase their risk for abuse of older people. Relationship factors, for example, dependency, conflict, also play a role in increasing the risk of abuse. Community issue, like example, poverty and limited services also increase the risk, and societal factors including ageism and discrimination which shape the environment. Recognizing these layers will help us to guide us on what are the best interventions to prevent, to act, or to respond to abuse of older people. I'll move on to the consequences of abuse of older people. Abuse of older people has serious effect to the individual, to the relationship, community, as well as the society level. It causes physical and psychological harm, reduce the quality of life, increase the healthcare costs, and it leads to hospitalization and institutionalization, which highlight the importance of abuse of older people as a public and social issue in general. So my question is, are we ready? Reflect, are we prepared to address abuse of older people in our community? So readiness goes beyond awareness. It involves recognizing the sign, responding appropriately, and safeguarding those older adults who are at risk. It requires commitment and commitment from the professional communities and families to uphold the dignity, safety, and the rights of our older people. The 2002 Toronto Declaration on Elder Abuse highlighted the global need to address this issue, recognizing abuse of older people as a key public health and human rights concern needing international action. It noted that lack of legal framework and that cases often go unaddressed due to missing laws. Preventing abuse require multi-sector involvement, especially primary healthcare workers who frequently encounter abuse, but they may not recognize it. Education and media play a vital role in raising awareness, combating stigma, and challenging stereotype about older people. Abuse is a universal problem, prevalent worldwide, often by someone known to the victim, mainly within family or care setting. So understanding abuse of older people require considering both cultural as well as gender context. And this is important, recognizing vulnerable group like the very old, those with limited capacity, women, and the poor. Prevention depends on the fostering a culture of intergenerational solidarity and non-violence. Countries should establish services like healthcare, legal aid, and police support to respond and prevent abuse. Various interventions from global to community level now focus on protection, dignity, empowerment, and social inclusion. So since the 22 Toronto Declaration, efforts to combat older abuse have advanced, leading to UN Decade of Healthy Aging, which emphasize prevention. So they have come up with the 5 priority for the United Nations Decade of Healthy Aging. WHO highlight 5 priority, which is strengthening evidence, improving responses, enhancing coordination, and promoting social changes to protect older adults' dignity and safety. So this priority highlights that healthcare professional role in identifying and preventing abuse as a cost-effective solution. These are the things that my studies is trying to answer, in which the research that my team have conducted or implemented are the culturally sensitive education for our family doctors, challenging the ageism, and evaluating the impact through data. So developing scalable effort solution and demonstrating their cost-saving benefit helps secure funding, ensuring sustainability. Linking global priorities with local effort aim to safeguard older people dignity in healthcare. So let's look at the global preparedness. So let's now consider our global preparedness in preventing and addressing abuse of older people. So if you can see here, 40% of the country have national plan, but only 17 have a national survey conducted. So the number shows that the global response remains limited and uneven. Without national framework or reliable data, progress is difficult. Strengthening global preparedness should be shared priority, making protecting older people the norm. Building on the UN Decade of Healthy Aging priorities, addressing abuse of older people requires action across multiple levels, from individual, relationship, community, and societal. So the socio-ecological model offers a comprehensive framework recognizing abuse as influenced by factors at the individual, relationship, community, and society. Applying this model enables the design of intervention that address abuse and its root cause, empowering individuals, supporting the caregiver, creating the safer community, and shaping the protective policy. Intervention targets various levels at individual, family, community, and society, reflecting the model multifaceted approach. Understanding intervention structures involve primary prevention, which is preventing abuse before it occurs, such as raising awareness, reducing ageism, and primary prevention, followed by secondary prevention, which seeks early detection to prevent harm, and while the tertiary addresses long-term effect, recovery, and recurrence. This level creates a continuum of care from prevention to response. Now I'll move on to talk about the role of primary healthcare professional. Why is it important for us as a family physician, on taking action towards abuse of older people? So basically, family physicians are the first contact of older people, playing a vital role in prevention. We can identify risk factors, provide education, support, and coordinate care. The regular contact will help us to identify the early sign of abuse, intervene, and reinforce protective measures. In Malaysia, older adults often use healthcare more due to their chronic illness, and victims of abuse, we found that they have visited the doctors twice as often as others, offering a higher chance for early detection. this preventing abuse. Evidence also showed that timely intervention can greatly improve the quality of life of affected individuals. This highlights that primary healthcare or family physician plays a key role in preventing and managing all the abuse of older people. So this brings to my first paper in which I published in 2020. I explored the challenges faced by family physician in Malaysia to intervene in abuse of older people. This study shows that healthcare professional, we also asked the healthcare professional how they feel to intervene in elder abuse in the primary care setting in Malaysia. So they feel that they play a vital role in addressing abuse of older people. However, they face multi-level challenges that limit their intervention or limit the effectiveness of their intervention. So this study shows that the barriers can be divided into a multi-level. One is at the clinical level, which involve the physician factors as well as the perceived patient factors. And it's move on to the organizational level as well as policy level. So in detail, the family physician mentioned that at the individual level, they have lack of awareness, empowerment, and they feel that they don't have enough knowledge and skill to intervene in abuse of older people. And they feel ageism is very common among the community. And in Malaysia, we have multicultural community. We have a few major races. For example, Malay, Chinese, and Indian are the three major races in Malaysia, followed by many other minorities in Malaysia. So basically, each culture have a different value when they are looking after of their older adults. And the family physician also feels that the community are also having lack of awareness, lack of education and training, support services, volunteer network, and again, ageism and cultural value also play a big role. When they move up to the organizational level, they feel that they are lack of support system. There's no guideline. There's no reporting system in Malaysia. For example, in Malaysia, we have a very comprehensive policy on how to act upon child abuse. However, when it comes to abuse of older people, we do not have any guideline. There's no reporting system, as well as there is no law or policy in place to assist our healthcare professional to take action when they suspect abuse of older people. So with this finding, we have a team known as Prevent Elder Abuse and Neglect in Malaysia. We call our team as PEACE, Universiti Malaya. So we have about 5 subgroups who from multidisciplinary, including the public health specialist, family medicine specialist, geriatrician, as well as the legal officers who are working on 5 subgroups. The first group looked into the epidemiology of abuse of older people in the community and institutional setting, while the second group looked into the caregiver, and the third group, which is my team, looked into the service provider, providing the education, training, and awareness for the service provider, especially the family physician as well as the primary healthcare nurses. And the other 2 groups look into the institutional and legal aspect of abuse of older people. I will focus on the project that I have worked on with the service provider, especially the family physician and the primary care nurses. So moving on from my first paper in which I explored the challenges of our family physician, and I found out that they are lacking of education as well as knowledge on how to intervene in elder abuse. Hence, this led me to conduct a systematic review looking into the effectiveness of educational intervention in improving primary healthcare service provider knowledge, identification, and management of elder abuse. So basically, this review shows that the education intervention improve the knowledge, identification, as well as the practice, and most of them are theory informed and are interactive educational intervention. So building on that review and local research, we developed SAFE. SAFE is known as supporting family doctors to address elder abuse. So this education is a focused, multimodal, and culturally sensitive face-to-face program on abuse of older people. SAFE, like I say, it stands for supporting family doctors to address elder abuse. It's structured around the SASO model, which is, we call it suspect. Whenever you are in the consultation room, when you suspect, you have to have a higher index of suspicion because all older adults is at risk of abuse. And you have to ask, you have to start questioning your patients, whether they have experienced abuse. And then you have to assess them, ask and assess them, and then provide support whenever necessary. And because in Malaysia, we don't have any law that asking the healthcare professional to report on elder abuse, so we have to give them option. This option is given because as an older adult, we also have to respect their autonomy in making decision rather than asking them to, you have to make a police report so the action is taken. So there are various factors involved when you are taking action towards the perpetrator, because most of the time the perpetrator are their own family member. So basically, the SAFE program is an evidence-based drawing on a published literature review, relevant policies in Malaysia, including the Malaysian National Health and Older Person Policy, and also expert opinion. And we divided the intervention into 4 modules. Our module 1 is on perception of older adults and aging. This is very important for our healthcare professional to understand what is the normal aging and what is abuse, okay? And understanding the aging, because certain abuse symptoms will be masked because of the aging process. For example, the bruises of your hand could be due to your, when you're aging, the skin are thinner, so they are unsure whether this is abuse or is it because of an aging process. An overview of abuse of older people, I think this is very important for our family physician to know the definition, the clinical presentation, and our module 4 covered the abuse of older people identification and management, and we included communication with older adults and the management principle. So basically, this is delivered face-to-face 5 hours using adult learning principle, which include the interactive lecture, reflective exercise, simulation, group work, and role play. This program is run by the family medicine specialist as well as the public health specialist. So in general, this safe education incorporates participant personal and cultural values, promoting reflection on belief and dilemma faced by the older adults in the clinical decision making. It addresses the ethnic diversity, language differences. So basically, in Malaysia, we have a lot of language. Okay, even Malaysia is our primary. Malay is our primary language. English is the second, but we have many other language, and also the caregiving customs. The program discusses filial piety and respect for elders, which may hinder mistreatment disclosure and acknowledging the private handling pressure. It explores the stigma, the hierarchical belief that keep older adults silent to preserve family harmony. Using case scenario and communication strategies, safe education help healthcare professional to handle culturally sensitive situation confidently and respectively. As I mentioned earlier, in Malaysia, there's no law requiring healthcare workers to report abuse of older people, with challenge like the absence of clinical guideline, limited resources, no formal reporting system, and no legal mandate. Existing structure, which include the older people wellness screening program. So we have this older people wellness screening program in which part of the questionnaire will ask about abuse, but there's only one question asking whether you have experienced abuse or not. And another strength that we have in Malaysia is that we have one-stop crisis center in many of the emergency department in the major hospital, in which we can refer the cases of abuse for the action to be taken immediately. So we have this clinical guideline which we developed in this research project. So safe intervention, which include the safe clinical guideline, this supports the family doctors to recognize and manage abuse in the primary care setting. We introduced the consultation model, which assists the doctor in addressing abuse in the consultation, as well as we introduced the clinical pathway. Earlier, before this, family physicians do not know how to act upon when they suspect abuse of older people. So we developed this clinical pathway and assist them on how to move if they suspect abuse or the patient is experiencing abuse. And we also introduced screening form for our nurses. As I mentioned earlier, we have all the adult screening form. However, it is only one question. So we expand for the screening form to allow our primary healthcare nurses to do the screening. And if the screening is highly suspicious that the patient is experiencing abuse, this group of older adults will be referred to the medical officer or the specialist and for further examination and history taking. And we develop a one-page documentation form. This documentation form went through a few process and evaluation by the doctors. You know, when you are in a primary care clinic, you are very busy, you can't fill in many forms. So this one-page documentation form is very easy, and we have a diagram for the doctors to chart whether there is any injury, because this may be useful when patient or the older adults would like to take legal action in future. And besides that, and to increase to expand the training program, we also developed the training of trainers manual. So this training of trainers manual is very useful for us to expand the delivery of knowledge, because this in Malaysia we have Peninsula Malaysia and also Eastern Malaysia is a very huge. So as a researcher, I can't go down and train everyone. So we collaborate with Ministry of Health, which is our biggest client. So we develop this training module so that more people will be trained and they can implement or screen for all the abuse of older adults in the primary care setting. So the strength of our intervention is because it is based on the adult learning theory. So this make the training more effective and engaging for family doctors. This theory points out that adults learn best when the context is relevant, practical, and problem-focused rather than theoretical. So we included the reflection, case-based discussion, group work, and question and answer to actively involve participants to ensure relevance to their clinical practice. So just an introduction on how we conducted the training. So we start our session by asking our family doctors and nurses to do a reflection on what they feel or what is their values, what is their belief and biases, and how this will influence their clinical decision. So we have this local short video known as Plastic Bowl. It's showing a common Malaysian family situation and older fathers losing dignity, symbolized by a plastic bowl, while his daughter struggle emotionally caring for him with little support from her husband. So this not only highlighting what the older people is experiencing, is also giving an idea how the caregiver is also having challenges, stress, and risk of neglect or abuse when only one person is taking care of the older adults. So this video prompt reflection on respecting elders and sharing caregiver duties. So this session was very useful because it lets the participant to reflect on what is happening in the community. And we included, basically our training is very interactive. We included a lecture that provide essential background on abuse of older people, which I explained earlier, including definition, clinical presentation, and local context. And this lecture followed by a case discussion where participants analyze the real-world scenarios and explore how to recognize, assess, and respond to abuse. And this is another interesting activity during the training. So we included the simulation exercise to help the doctor to better understand what is aging process and the challenges and dilemma all the adult may face. By experiencing this scenario in a safe environment, doctor can build insight and confidence before applying their skills in real clinical practice. And we also have role play on communication with the older adults, allowing participants to practice addressing the sensitive issue. And this exercise helps them to learn how to ask difficult questions, offer support, and respond appropriately. So basically, if you see the simulation activity, the older adults with the limited vision are trying to put the thread in the needle. You know, they struggle to do certain activities with the limitation vision, hearing, and sensory. So group work also being conducted. It fosters peer learning and problem solving throughout the program. Before lectures, participants complete a short group task to share clinical experience and reflect on the real cases. This active learning approach is a flipped classroom and help doctors to activate prior knowledge and before new information is given. So they do the group work first before they have the interactive lecture. So during discussion, participants explore cases, exchange perspective, and develop intervention strategies. So these activities make the education intervention more practical, experiential, and relevant, empowering family doctors to effectively identify and manage abuse of older people in the primary care sector. And this brings to the award-winning paper of the process evaluation of supporting family doctors to address elder abuse intervention in Malaysia. Is a mixed method evaluation. So the safe intervention include the safe education program as well as safe clinical guideline, which they implemented after the training in the primary healthcare setting. So based on this effective theoretical framework help us to understand what intervention cause change, the TBP or theory of planned behavior model, social and health behavior by linking attitude, subjective norm, and perceived behavioral control to intention and action for family doctors addressing abuse of older people. These domains connect their belief to behavior. Additional factor like internal or knowledge, skill gained from the training, and external time, resources, support influences also part of this action. The safe training and guideline aim to improve family doctors' ability to identify and manage older adults in the community setting or at the primary care level. So the first phase of the study is quantitative, which include the pre and post test study in 6 months, which included 160 family doctors assessing the safe education program impact on their knowledge, attitude, subjective norm, and perceived behavioral control in addressing abuse of older people. Knowledge score increases significantly immediately post-intervention and stayed beyond baseline at 6 months with the p-value of 0.01. While attitude score also rose significantly and remained above baseline at 6 months. Subjective norm increased immediately at 6 months. The 3-month follow-up showed a non-significant decrease, but the score stayed above the baseline. Perceived behavioral control score increased immediately, and despite some decline during the follow-up, it remained above the baseline. The second phase is a qualitative study was conducted among 39 participants who have participated in the educational training as well as implemented the identification, recognition, as well as management of abuse of older people in the clinical setting. So this qualitative study among 39 family doctors showed that the increase of knowledge of immediately after training, it sustained gain at the 6 month, and the teams of awareness increased their awareness, confidence, and practical training underpinning these findings. Attitude also improved significantly post-intervention with empathy and self-reflection emerging as a key factor supporting these lasting changes. The study also reveals a positive perception supported by colleagues. Okay, their subjective norm and perceived control increased doctors confident to identify and manage elder abuse. While there are some decline occurring over time, the score remains higher than baseline, indicating the lasting effect. Qualitative findings or insight highlight the importance of social support and ongoing reinforcement to maintain behavioral improvement. So in that study also, we have a few recommendations that been suggested by the participants. So as Malaysia is an aging population facing insufficient preparedness of elder abuse, which has a profound social welfare and healthcare impact. Unlike child abuse protection, in Malaysia, we have a team called SCAN team. It's a suspect child abuse and neglect team. So this suggests that for older abuse of older adult, we also use this multidisciplinary approach, which can adopted, and support also can be enhanced by establishing a clinical pathway using our one-stop crisis center nationwide for all coordinated victim support. So family doctors need a unified approach with access to social worker and geriatrician for holistic care. Currently, Malaysia's strategy is still at the early stages with limited policy prioritization and advocacy. More resources should be allocated to help family doctors protect older adults, and they suggested implementing non-punitive law and restorative justice could safeguard the older adults. They do not suggest mandatory reporting. They suggested that if you report, they will have a non-punitive law. So nationwide adoption of safe clinical guidelines, including pathway and screening, is recommended. Other abuse intervention program like safe training should be integrated into our medical education, which is a systematic multidisciplinary approach is crucial for family doctors to assess and respond to elder abuse effectively. Building on this safe ed process evaluation, I also published a chapter on what are the updates or progress in Asia Pacific region to safeguard and protect older adults from abuse and neglect. So the next, we will discuss on what are the good practices to intervene in abuse of elder neglects learned from the other Asia Pacific region countries. Okay? So what they suggest is capacity building through evidence-based education intervention, in which the safe training model is one of the example. So they suggest that training should be multimodal, locally tailored, and culturally sensitive, so healthcare providers can respond confidently. Key components of the training include recognizing signs of abuse, knowing intervention protocol, and developing communication, including confidentiality, autonomy, and reporting duties. So cultural competency is essential as norms influence how abuse is perceived, especially in Malaysia with a multicultural society. So education also emphasizes ethical responsibility, legal obligation, and practical strategy like case scenario and role play. Most importantly, it should foster a proactive, compassionate, and zero tolerance attitude towards abuse of older people. The next good practice is screening and assessment. Although the US PSDF has concluded that there is insufficient evidence to determine the benefit and risk of screening for abuse of older people, but as a healthcare professional, we should have an active role in asking our patient if we suspect. We have to be sensitive and have a regular screening. And I'm sure there are a lot of structural tools and framework outside there that we can use in our local setting. Recognizing subtle signs and contextual clues and interdisciplinary assessment team is crucial to ensure that the patient receives the best care. Next is guideline and protocol. So clear guidelines and reporting system is very helpful for the doctors to take action involving the interdisciplinary and multidisciplinary collaboration, because addressing abuse of older people is not solely on a primary care or family physician responsibility. It has to involve other disciplines, for example, the social worker, the geriatrician taking action on the abuse consequences like physical abuse, support system for the professional, harm reduction and safety. And for example, in Malaysia, what they suggest was to follow our suspected child abuse and neglect module, which is very successful in child abuse cases, which can be adopted for abuse of older people. Again, next good practice will be community-based intervention. So strengthening social connections, support network is very important. Home visit, outreach by healthcare professionals will be able to help us to identify abuse, especially when the older adults is unable to come to the clinical setting. And in Malaysia, we have community and senior activity centers in which adults more than 50 they are encouraged to join the activities in the senior activity center, in which there will be a doctor, there will be a nurse, a physiotherapist, occupational therapist doing certain activities. So we feel that that community center is very important and is a very nice. If you want to identify abuse, it will be a good environment because they feel safe to talk with each other. And reducing social isolation is also important. Next will be policy and law. As we say, we can't punish the caregiver. So what they suggest is a non-punitive or rehabilitative law. Have a national policy so that we have adequate resources, access to healthcare. So for example, if we suspect older adults is being abused and we reported on their caregiver, where are we going to place these older people? So we need these adequate resources for us to place this older person in a safe environment. And of course, in Asia Pacific region, certain countries or regions have enacted protective law. For example, in Singapore, Philippines, China, Thailand, Hong Kong, India, and Japan. So moving on, charting the path forward, I will go with the WHO recommendation, which I think they are still lacking on a high quality research data on abuse of older people, especially data on prevalence, risk, and protective factor. For measurement instrument, we require development of measurement instrument. Effective intervention must be locally tailored and culturally sensitive, and international regional collaboration. Not to forget in abuse of older people intervention, we should go on with the technology by introducing apps, telehealth, online reporting to improve detection and response. And with that in mind, I also have published a systematic review on psychometric properties of instrument for measuring abuse of older people in community and institutional setting. This is a collaboration with WHO. And we found that there are actually about 68 abuse of older people measurement instrument used by all the researchers globally. And there are 46 original and 22 modified, 56 used to measure in community and 10 in the institution. And we evaluate the psychometric property using the COSMIN guideline. And we found that there are the psychometric property they are lack sufficient in their quality and evidence for us to recommend what would be the best measurement instrument to use to measure the prevalence of elder abuse in the community and institution. And of course, the next one is tackling ageism and raising awareness. So we have to educate the community, promote respect, empathy, and inclusion, recognize signs of abuse, and encourage reporting, like public campaigns to teach people, older adults and caregiver. Another way is to build an age-friendly environment and support network for them. The next one is centering the resources and infrastructure. So we have to have older adults and community center. Service provider will require training, guideline, and educational materials. Safety and help center, such as introducing hotline and counseling. Support center, counseling shelters, respite care. Because we feel that we also have to consider the caregiver burden, in which that will increase the risk of abuse of older people. And of course, tackling the economic pressure. Legal and ethical measure, whether we want to enact a comprehensive law that define abuse of older people, giving penalties or protect the victims' right, reporting, whether you want to implement mandatory reporting, and rehabilitative process, especially for the perpetrator. So in conclusion, I think the role of family doctors, we are in a crucial and unique position to take action upon abuse of older people. Educational intervention effective in improving family doctors' knowledge, attitude, and subjective norm. And we need a multidisciplinary team approach. This is not solely one person job in which everyone has to take action together, strengthen the system and policy support. That other strategies will be to empower our older people to age healthily and also raise community awareness. With that, I end my presentation. We usually celebrate is a campaign of World Elder Abuse every year on June 15. So this was the last year's theme. Thank you.
Thank you so much, Dr. Mydin. This has been a very impressive and comprehensive presentation, much beyond more of what we expected. So, and I really appreciate that you have presented your research agenda. In fact, so that has allowed us to know what is going on with regard to abuse of elders in Malaysia and extremely well structured. So thank you very much. Maybe if you stop sharing, the conversation over the next 50 minutes will be more friendly. So we have Dr. Jaffe that he has already 2 questions. So Mark, go ahead, please. Mark?
I think you muted him when you're picking him up on the mic, so you have to unmute him probably.
Okay, it's already okay.
Yeah,
Mark,
can you hear me? Can you hear me,
yes,
Cheryl?
yes, now yes.
Oh,
Okay,
that's interesting. I didn't have sound earlier. I've actually put the questions in the chat, but I'll elaborate. Firstly, thank you for this presentation. It really does cover the range of issues with regard to elder mistreatment. A few questions. Firstly, how did you get family doctors to take part in your education program? Your sample size at one point was 160. That's very impressive. We don't do that well in getting family doctors to attend these things. And then in the second part of your research, you're down to about 35. So what means did you use to bring doctors in and to stay committed? You had a dropout rate from 160 down to 35, 39. So tell us a little bit about your interface with the family doctors.
Thank you for the question. So, so I'm from the university setting. So as a researcher, we collaborate with our colleague in Ministry of Health, in which they are the main people who run the primary healthcare clinic in Malaysia. So how we approached them was we went to one state known as Penang Island in Malaysia, in which we collaborate with the public health officer in the state, and we invited all the family doctors to attend our training session, which is 5-hour training session, and we conducted 1 week training session with a different group of doctors. So basically, it's from the higher order in which our public health officer ordered them to attend the training, and it's part of their continuous medical education, and they got the TPD points, and it helps them with their continuous medical education points. So that's how we got all these 160 doctors to join our training. So we went down to their place and conduct the training. We did not ask them to come to our place, so it's more convenient for them. So we, as a researcher, we go down and invite them. So basically, we get a good follow-up rate as we have a very dedicated team looking after this when we are conducting the research. The second phase, which is the qualitative study, that is when we use the data saturation, in which by 36 participants, we already reached a data saturation. We actually wanted to invite everyone come back and give us the feedback on the implementation as well as the education, but we only managed to conduct a few sessions and we reached our data saturation, and that's why we stopped the qualitative study.
Thank you. My second question has to do with specific intervention. It's clear from your presentation that family doctors are expected to be involved in the detection process. I'm not clear as to whether you expected them to be involved in intervention, and if so, how do family doctors feel about that? The question comes from the fact that here in Canada, most family doctors would feel that the intervention portion is not within the responsibility of healthcare, but is a social issue that is way beyond their involvement. So what did you expect, or what are you expecting in the intervention side from family doctors, if anything?
Okay, so basically in our educational intervention, we included the clinical guideline, which also included the clinical pathway in which how the family doctors, if they identify or they suspect abuse of older people, we have pathway for them on how to move for the next action. So the next action depends on the severity of the abuse. If the patient or the older adults is severely injured, the best is to send the patient to emergency department, in which we have one-stop crisis center. We have a multidisciplinary team in our one-stop crisis center, which include the legal officer, the police officer, as well as the social worker in one setting in our emergency department. But that is when someone is severely injured and require medical attention. But sometimes these older people who don't have any physical injury and like neglect and so on, we have a different pathway in which the next step is to, of course, to get involvement of the social worker. So basically in our primary care setting, we have a good collaboration with the social worker from the Ministry of Women and Community, in which we connect this older person to the social worker. Like you say, when it comes to the intervention, is sometimes beyond what a family physician can do. So we can identify, we can manage their medical problem, we can manage their acute problem, but sometimes the social aspect is usually managed by our social worker.
Thank you.
Thank you so much, Mark and Fadzilah. More questions, comments? Yes, go ahead. Anne, please go ahead.
Yeah, thank you. Thank you very much. It was a very interesting presentation. We're doing some work with older people in Botswana, and I found it very interesting. I wanted to ask you, when you were talking about the guidelines, development of the guidelines, to what extent were you able to involve older people themselves in developing those guidelines?
Okay, so basically how we develop the guideline, that is the part of the limitation in which the stakeholders, older adult was not included during the development of the guideline. So basically who involved in the development of guideline are the legal officer, police officer, the geriatrician, the public health officer, as well as our family medicine specialist. So the stakeholder from the older adults is one of the limitations we did not include in our study.
Thanks very much.
Anne is asking you this question because she's an expert in participation science, one of the experts of participation science in our department. So and we promote a lot, particularly I think for this type of topic, right? And this type
yes,
of...
I mean, we're trying in both Botswana and indeed in Montreal it's a project looking at dementia prevention in older people and very much getting their inputs into the process. So it's of course it's it's a different element to it, because obviously if you're going to try to involve the older people, it's a whole new piece of work, you know, a different piece of work. But what do you think? Do you think the guidelines would have been different if you'd been able to involve the older people more? What's your feeling about it?
Definitely, because we are only listening from the service provider views. We didn't hear from the older adults. Definitely, I think there will be some other input from the older adults that may help to enhance the current guideline. You know, we can listen from their part what will be the best and how do they want us to take action upon if they reveal that they are being abused. I'm sure there will be some other interesting finding that can enhance the current guideline, definitely.
Maybe for your next project.
Yeah. Thank you. Thank you. More questions? Comments? Waiting for other people. I have a question for you, Fadzilah. You are the go ahead, please, Marwa. Go ahead. I will go after you. Go ahead, please.
Okay, perfect. Sorry. Thank you so much. Let me just lower my hand. Okay. Thank you so much for this presentation. It was very interesting. So I'm doing my PhD work on not older adults, but I did my master on it, but on people living with dementia and their care partners. And I know that a huge part of abuse is also neglect. So I was wondering, like, I know that the stakeholders, like the older adults themselves, are not included to as co-participant or to create those guidelines and to participate fully in it. But what about their families or their care partners or the caregiver, if they have one? Are they also involved, and maybe they have tools to maybe improve that neglect aspect of abuse? Maybe they don't have the tools. That's what I'm wondering. Like, is your research addressing this part as well?
We have 5 subgroup with a different aspect assessing on different stakeholders, and one of the study is among the caregivers. So I was not involved directly, but actually the team look after the caregivers, providing training for them on how to take care of older adults. So basically, it's teaching them on how to take care of the adults. At the same time, they also look into the caregiver stress and burnout. So we have that study as one of the subgroup of our peace team. Yes.
Okay, perfect. Thank you so much for answering that.
Thank you. Because this is an international, the scope of this webinar is very international. We will jump now in Argentina. So Paula, go ahead with your comment, please.
Hi, how are you? Thank you for the talk. It was very interesting. I just comment about my experience. And in Argentina, we are taught that we should advocate for the patients that are more than 65 years old, but there's no guideline on how to do that. So this was very interesting.
Yeah, so basically this is the first guideline in Malaysia. And prior to that, we also do not have any guideline how to take action when we suspect abuse of older people.
But maybe, Paula, you could replicate what
Yeah.
has done in Malaysia and to test if these forms could work in Argentina. Okay.
I'm happy to work. If you like to connect with me, you can email me.
Thank you.
Actually, we are working with a team in Hong Kong. They are going to replicate our studies in Hong Kong, and that is our next step to replicate this study in another setting.
Thank you.
I invite people here in Montreal if you want to. So happy to connect you with Fadzilah in that regard. We are almost running out of time, but I would like to ask you a last question if there is no other comment. You are the co-recipient of the Pierre Curie International Awards in its edition 2025. You have presented your whole research agenda, but we create these awards to celebrate Dr. Plu's contribution to the advancement in mixed methods research in health, particularly. So, and we have learned with him that one thing is what traditionally is called quantitative research. Another stream is qualitative, but when we talk about mixed methods, there is something else, because we could conduct focused quantitative research, focused qualitative research, but what is this plus value, if any, for you to, in the paper that was awarded, you adopt a mixed methods approach? What was the plus value for you at the methodological level?
Okay, so my last paper, which was the process evaluation paper, I included a quantitative and qualitative study. The first phase was the quantitative study, pre and post. We managed to see how this intervention did improve their knowledge, attitude, and practice, but we could not find why. So how and why. So that's why the qualitative studies that we conducted after the implementation of the program or the implementation of the clinical guideline, after 1 year, we called back all the doctors who participated in our study to understand why their knowledge able to sustain, why their attitude changed, and why their subjective norm changed. However, we don't see much changes in their perceived behavioral control. So we merge our findings from the qualitative and question them why there's no changes in your action, and we found that actually the family doctors are trying their best to take action. However, they feel that the support from the organization as well as the community is still lacking. So basically, our study shows that despite we educating our family physician, we still have to look into other factors that influence their action. Basically, the social ecological model is a very good model to explain this, in which education managed to change at the individual level, but there are so many other things that hinders doctors' action to take effective action towards abuse of older adults. So there are still things that we in Malaysia can do to improve the organization as well as at the policy level. So that explains the findings of our first phase, which is the quantitative study.
Okay. Thank you so much. I think now, yes, we are running out of time and people are leaving. So please join me to congratulate Dr. Mydin for this excellent presentation. And it has been, as I said before, a very nice way to wrap up our series of webinars in this academic year 25-26. So thank you very much. And thank you all of you for spending your lunchtime with the FMER group. Thank you. Bye-bye.
Thank you very much for joining me. Bye-bye.